training. This is something that a lot of people haven't been trained to do. It's actually not too hard to do, and there's actually manuals that practitioners can buy that are very good by Doug Woods. And usually it only takes about 8 sessions to teach them this. So you're not talking about really long, Freudian type psychotherapy. You're talking about a fairly quick type of treatment. But you really work on getting them to identify that premonitory urge, when are the tics happening, getting them to be aware of the tics, and then you teach them how to do competing responses. So a kid that may be ticking like this, you would teach them to contract the muscle down when they had that urge. And then you support them and reward them for trying to do these therapies. And this is a habit reversal therapy study showing baseline tic severity scores. Post-treatment, better, obviously not completely gone away. But for the most part, it's maintaining at 3 months. So therapy works. And I would say this is not for every kid with tics, because you get these kids that got really, really severe tics. They have multiple tics occurring at the same time. It's really hard for them to focus and identify a certain problematic area when they're ticking so violently. But if you have one that has 2 or 3, like they may have an eye blink or nose wrinkle, or they're flailing their arm or shoulder, you can really focus on those and give them good training and make a big impact. And this is tic severity at baseline, CBIT group in orange, and at end of study. And this is still, these kids still have fairly significant tics, but it may be that the score is down because their intensity or their impairment is better, and that can make a big impact, because when you look at how many had very much or much improved, it was 52% in the treatment group versus 18% in the control group. This is pretty much what we did in our previous guidelines. Mild tics, no treatment. Moderate tics, alpha-2 agonists or atypicals. Severe tics, try another atypical or go to the typicals. And this is actually from Practice Parameter, and I actually modified a couple of these, but this kind of gives you the empirical support for the studies that have been out there for treating tic disorders. And probably the ones I think that are currently most in vogue and have some decent support are pimozide, risperidone, aripiprazole, and guanfacine. And I would say I'm seeing these mostly used, and there's pretty good support for all those. And I did an open label trial that was just published not too long ago, looking at kids with Tourette's. And a lot of these kids also had OCD and ADHD, and some had some depressive symptoms. And I was very conservative in the dosing. I started as low as I could make the pills work. And we ended up with an average dosing of 3.3 milligrams for these kids with tics. They had significant improvement in their Tourette's. But the thing that was sort of surprising was how much improvement they also had in their OCD symptoms. And some of them had improvement as well in their ADHD and depressive symptoms. And so it was a very, very well tolerated. We did all kinds of safety labs. We did EKGs and everything. Had nothing that was significant that came out of that, except for they on average gained about 5 to 7 pounds. So OCD, anxiety disorder. They've been talking about taking it out of the anxiety disorders in the DSM-5. Usually these individuals have insight, but a lot of kids do not, and it's not required for kids to have insight. And the thing that I see a lot is that these symptoms can be very situation specific, where the child may function okay at school, but when they get home all hell breaks loose because they've got the whole family, walking on eggshells around their OCD. When you see OCD in children, it tends to be more complex than you would see in one that started in an older individual. They tend to have not as good of a treatment response, and a lot of that I'll show is because of the comorbidity, and it tends to be more genetic. Just a list of some of the obsessions and compulsions. I think a lot of people sometimes think of OCD as only hand washing, but it can be very complex with issues of scrupulosity, counting, mental compulsions, hoarding. It has all kinds of different presentations. And I think with the DSM-5, this is relevant for the developmental perspective, more common in males in the younger age group. They tend to have more aggression and catastrophic kind of obsessions and compulsions. As they get older, they move more into the religious and the sexual ones, which is probably developmentally appropriate. The younger ones have more separation anxiety, and they have more tics. We have pretty good data on effective treatments for OCD. Cognitive behavioral therapy is a gold standard. And then when they've done various studies, it actually shows to be effective, and I'll go over some of those. Anybody a Monk fan? This was him getting exposure response prevention from Howie Mandel, who interestingly truly has OCD. And this is the first time in all the whole series that he was actually treated appropriately, and it was by a cult leader. So, so this is my approach to childhood OCD. And I never would start a medication on a child with mild OCD. I would always recommend cognitive behavioral therapy. And moderate, I think, is a good argument for trying both. And then severe OCD, and I see quite a few of these kids where they cannot even fathom engaging in CBT until their anxiety level is down. They just can't do it. Positive predictive trials, I would say most of the SSRIs are appropriate. I have no favorite, or other than I tend to stay away from paroxetine because of all the issues with it. But I think any of the SSRIs are appropriate treatment options. When they did the meta-analysis, difference in response rate, major depression showed the lowest. OCD was sort of in the median, and non-OCD anxiety actually has the best response. So you can see that this is not a cure-all for these kids with OCD. If they got pure anxiety disorder, it's a pretty good option just to use medication. But with OCD, I think you're going to need more. POTS trials are probably one of the best studies that's been done, and that's where they use CBT, combination treatment, placebo, looking to see if there was a difference in these different arms. And what they found is combination therapy worked best. No surprise there. CBT actually beat out sertraline and then placebo. And that's just showing combination, big drop, and CBT, not too bad. Sertraline, not looking as impressive. So this is one of the slides I just wanted to show from Dan Geller's study. I actually did this study with Dan Geller, looking at treatment response based on comorbidity. They tended to respond better if they didn't have a comorbid condition, 75% if they had only OCD. If they had ODD and tic disorders, it dropped down quite a lot. And this is showing ODD, tic, and this is all patients, and this is, let me get my colors backwards, this is any with greater than 1. So it drops down the more comorbid disorders they have. And I think that's very important, because then you're going to have to come up with some other strategies to work on these kids. And John March did a post-analysis on the study showing those that had tics did not respond quite as well. And they actually, in that group, they did better with the CBT as well. This is one just starting to show some of the phenomenology. These children often have impulse control disorders like skin picking, about 13%, nail biting, 10%, and they're more likely to have the co-occurring tic disorder. The ones that have the impulse control disorders, that is. When you see OCD and tics, which in my practice that's probably 65–70% of the kids, you have a really much more complex issue to deal with, because you're really going to have a hard time finding one therapy that's going to treat both issues. In this case, you might want to use, if you're, pharmacologically, the SSRIs and the D2 blockers together. There's really virtually no studies other than a few open label and case reports guiding us on combination therapy in children with these type of disorders, even though they're very, very common. But these are some of the things that are thought, genetic. These kids do have more prenatal events in their history. Some people think it's a developmental disorder of synaptic neurotransmission. There may be issues with chemical exposures and infections. which I have an interest in. And